Good afternoon, everyone. This is David Dijak. I'm the Associate Executive Director for Programs at NACCHO, and we'd like to welcome you to our Chikungunya webinar this afternoon. This has been an important issue to us for quite a while, and we've been tracking this to be sure that we provide you the information that you need to be out in front of this in your own personal jurisdictions. We'd like to recognize and thank Dr. Mark Fisher, who's out in Fort Collins, Colorado, for joining us for this effort this afternoon, and we are particularly thankful to CDC for their partnership. Chikungunya is an interesting virus in as much that there's not a lot of mortality or any mortality associated with it, but you'll certainly be sick, and our constituents will certainly be sick if they happen to suffer from an exposure. We hope to build off the lessons learned from Ebola and leverage the new and strengthened community partnerships that we developed over the last several months. We encourage you to check the CDC and NACCHO websites for updated information as the spring turns into summer, and we want you to know that we're committed to ensuring that you have the information and the resources that you need throughout the summer if, in fact, chikungunya comes to impact us. Having said that, again, we'd like to thank CDC and Mark Fisher there in Fort Collins, and I'd like to turn this over to my colleague, Lisa Brown, who will run us through some of the logistics.
Thanks, Dave. Hello, everyone, and welcome to today's webinar. My name is Lisa Brown, and I also am from NACCHO. I will be facilitating today's webinar, but before we start off the presentation, I have a few housekeeping items. Today's webinar will be a 40-minute presentation, followed by a 15-minute question and answer session. Participants will be able to ask questions via the Adobe Connect chat box and the ReadyTalk conference line. This number is available in the chat box on the Adobe Connect. I will be alternating between the two modes. Please note that if you are asking a question via the ReadyTalk conference line, please mute your computer speakers. This will avoid echo. Also, today's webinar has closed captioning and will be recorded and archived for individuals to access at a later date. So today's speaker is Dr. Mark Fisher. Dr. Mark Fisher is a medical epidemiologist with the CDC Arboviral Diseases Branch in Fort Collins, Colorado. His research activities include surveillance and epidemiology of arthropod-borne viral diseases and the evaluation and use of arboviral vaccines. Welcome, Dr. Fisher, and you may begin your presentation. Thank you.
Thank you, Lisa, and thank you to NACCHO for sponsoring today's webinar. Today I will provide an overview of the epidemiology, clinical findings, diagnosis, treatment, and prevention of chikungunya virus infections, and update the status of chikungunya in the United States. In addition, I want to emphasize the role of health departments and healthcare providers in mitigating the risk of local transmission of chikungunya virus in the United States through mosquito control, public education, and timely recognition and reporting of cases. Chikungunya is a mosquito-borne viral disease characterized by the acute onset of fever and often severe polyarthralgia. The disease often occurs in large outbreaks with high attack rates, affecting 1/3 to 3/4 of the population in areas where the virus is circulating. Outbreaks of chikungunya have occurred in countries in Africa, Asia, Europe, and the Indian and Pacific Oceans. In late 2013, the first locally acquired cases of chikungunya were reported in the Americas on islands in the Caribbean. This map shows countries that have ever reported local transmission of chikungunya virus. Although a recent publication suggests there may be historic reports of possible chikungunya outbreaks dating back to the 1700s, the virus was first isolated and identified in Tanzania in the 1950s. Over the next 50 years, outbreaks occurred sporadically in parts of Africa and South Asia. Beginning in 2004, there was a large expansion in the number of chikungunya disease cases reported throughout many countries, South Asia, the Indian and Pacific Oceans, and even a few countries in Europe. In late 2013, while outbreaks continued in South Asia and parts of the Western Pacific, the first local transmission of chikungunya virus in the Americas was identified in Caribbean countries and territories. Since then, the virus has spread throughout much of the Western Hemisphere. This graph shows the progression of chikungunya virus in the Americas. The yellow bars show the cumulative number of countries or territories that have reported local transmission between December 2013 and March 2015. The red line shows the number of suspected or confirmed cases reported to the Pan American Health Organization over the same time frame. Since December 2013, local transmission of chikungunya virus has been identified in 44 countries or territories throughout the Americas, with more than 1.3 million cases reported to PAHO from affected areas. It is important to note that less than 1% of all the chikungunya cases reported to PAHO are laboratory confirmed. Of the 1.35 million reported cases, more than 1.1 million are suspected cases reported from the Dominican Republic, Colombia, El Salvador, Guadalupe, Martinique, and Haiti alone. In recent months, some of the first affected areas have been declaring an end to their outbreaks. Prior to 2006, chikungunya virus infections were rarely identified in U.S. travelers. From 2006 through 2013, studies identified an average of 28 people per year in the United States with recent chikungunya virus infection. All were travelers visiting or returning to the United States from affected areas in Asia, Africa, or the Indian Ocean. None of these imported cases resulted in known local transmission in the United States. In 2014, local transmission was first identified in the Caribbean, and large numbers of imported chikungunya cases were reported among U.S. travelers returning from affected areas in the Americas. Local transmission was identified in Florida, Puerto Rico, and the U.S. Virgin Islands. In 2014, chikungunya was not a nationally notifiable disease in the United States. However, chikungunya cases could be reported to ARBONET, the National Surveillance System for Arboviral Diseases. Based on provisional data for 2014, a total of 2,492 laboratory-confirmed chikungunya virus disease cases were reported to ARBONET from 47 U.S. states. 11 locally transmitted cases were reported from Florida. All other cases occurred in travelers returning from affected areas. Of the 2,481 travel-associated cases reported from U.S. states in 2014, two-thirds occurred among residents of 5 states: New York, Florida, New Jersey, Massachusetts, and Pennsylvania. 4,513 laboratory-confirmed chikungunya cases were reported to ARBONET from U.S. territories in 2014. Most were locally transmitted cases reported from Puerto Rico. More than 30,000 additional suspected cases without completed laboratory testing were reported to the Puerto Rico and U.S. Virgin Island Departments of Health. In 2015, chikungunya virus disease became a nationally notifiable condition. Thus far in 2015, a total of 77 laboratory-confirmed chikungunya virus cases have been reported to ARBONET from 21 U.S. states. All reported cases have occurred in travelers returning from affected areas. No locally transmitted cases have been reported from U.S. states thus far. To date, Florida and New York have again reported the most travel-associated chikungunya cases in 2015, followed by Maryland, California, and Texas. Thus far in 2015, a total of 56 laboratory-confirmed locally transmitted cases have been reported to ARBONET from Puerto Rico and the U.S. Virgin Islands. Chikungunya virus is a single-stranded RNA virus in the genus alphavirus, family Togaviridae. It is closely related to other alphaviruses that can cause similar disease in humans, such as Mayaro, Anyang-Yang, and Ross River viruses. Chikungunya virus is primarily transmitted to humans by Aedes aegypti or Aedes albopictus mosquitoes. These mosquitoes also transmit dengue virus. Aedes aegypti and Aedes albopictus larvae develop in discarded tires and household containers. They are aggressive daytime biters, which means that typical prevention messages for West Nile virus to reduce evening and nighttime mosquito exposures are less effective. Aedes aegypti and Aedes albopictus are widely distributed throughout the Americas, including parts of the United States. These maps show the approximate geographic distribution of these mosquito species in the United States based on reports to ARBONET and other published sources. Similar to dengue virus, chikungunya virus is maintained in an anthropogenic transmission cycle. Infected people develop high levels of the virus in their blood and are capable of infecting mosquitoes that feed on them while they are viremic. These mosquitoes can then transmit the virus to other people, leading to person-to-mosquito-to-person transmission of the virus. Several other modes of chikungunya virus transmission have been documented, though they are rare. Intrapartum transmission is well described when the mother was viremic around the time of delivery. In utero transmission, early in the second trimester, has been reported in 3 miscarriages where chikungunya viral RNA could be detected in fetal tissue. The virus has been transmitted through percutaneous needle stick and laboratory exposure to infected blood or viral culture. Given that humans develop a high level of viremia, it is expected, but not yet documented, that transmission can occur through blood transfusions and organ or tissue transplantation. 2 small studies have evaluated breast milk from viremic women and did not identify chikungunya virus or viral RNA in the milk, making transmission through breast milk less likely. The majority of people infected with chikungunya virus develop clinical symptoms. The range of symptomatic infections documented through serosurveys and follow-up questionnaires has been between 72 and 97% of infected persons. This is different from the proportion of people who develop symptoms from other mosquito-borne viruses such as West Nile or dengue, where the majority of persons are asymptomatic following infection. For symptomatic chikungunya virus infections, the incubation period from mosquito bite to disease onset is usually between 3 and 7 days, with a range of 1 to 12 days. The primary clinical symptoms of chikungunya virus infection are fever and polyarthralgia. The arthralgia are usually bilateral and symmetric, and the pain can be severe and debilitating. Other clinical signs and symptoms commonly seen with chikungunya virus disease include headache, myalgia, arthritis, conjunctivitis, nausea, vomiting, and a maculopapular rash. The rash typically occurs 2 to 5 days after the onset of fever and involves the trunk and extremities, but can also include palms, soles, and face. The rash can also present as a diffuse erythema that blanches with pressure. Some of the clinical laboratory findings that can be seen with chikungunya virus infection include lymphopenia, thrombocytopenia, elevated creatinine, or elevated hepatic transaminases. During large outbreaks of chikungunya that occurred roughly 10 years ago, a number of atypical disease manifestations were noted, including eye involvement with uveitis or retinitis. Hepatitis, nephritis, and myocarditis were also reported. Hemorrhage was noted in a small proportion of cases. There were several neurologic disease manifestations noted, such as myelitis, cranial nerve palsies, Guillain-Barré syndrome, and meningoencephalitis. Finally, unusual dermatologic manifestations were reported, such as bullous skin lesions. These were described mostly in infants and neonates exposed to the virus during the intrapartum period. Groups at risk for hospitalization or atypical disease manifestations include neonates exposed intrapartum, adults over 65 years of age, and people with underlying medical conditions such as diabetes, hypertension, or cardiovascular disease. The acute symptoms of chikungunya typically resolve in 7 to 10 days. Mortality is rare and mostly occurs in older adults. In the months following acute illness, some patients will have a relapse of rheumatologic symptoms such as polyarthralgia, polyarthritis, tenosynovitis, or Raynaud's syndrome. Studies have reported variable proportions ranging from 5 to 60% of patients with persistent joint pains for months or years following their illness. Risk factors for persistent joint disease include pre-existing joint disease, higher initial viremia levels, or in one study, HLA subtype. A number of diagnostic tests can be performed for evidence of chikungunya virus infection. These include culture to detect virus, RT-PCR to detect viral RNA, serology to detect IgM and neutralizing antibodies, or paired serology to detect a 4-fold or greater rise in virus-specific antibody titers. Virus-specific titers can be determined either by plaque reduction neutralization test or immunofluorescence assay. Finally, immunohistochemical staining for viral antigens can also be performed on fixed tissues. This table shows the recommended timing for using some of the diagnostic tests discussed on the last slide. Virus may be cultured from the blood of symptomatic people within the first 3 days post-illness onset. RT-PCR is usually positive in the first 5 days after illness onset, although RNA may be detected for up to 8 days after illness onset. Serum specimens collected 4 or more days after symptom should also be evaluated for virus-specific IgM antibodies. Healthcare providers should contact their local health department to facilitate diagnostic testing. Testing for chikungunya virus is available through CDC, several state health departments, and at least one commercial laboratory. Focus Diagnostics performs an in-house RT-PCR and IgM and IgG antibody testing. However, commercial laboratories will only perform the test that is ordered, and healthcare providers should be careful to request the proper test based on the type and timing of the available specimens. Several chikungunya virus IgM antibody kits are commercially available, but they are not yet cleared by FDA for routine diagnostic use. CDC evaluated 9 commercially available chikungunya virus IgM antibody assays. 1 IFA and 4 ELISA assays are available for purchase in the United States. The IFA and 2 of the ELISA assays performed well in the evaluation, showing high concordance with the CDC in-house MAC ELISA. To increase public health testing capacity for chikungunya virus, CDC will publish the evaluation of the commercially available IgM antibody assays. Until those results are published and the assays available, CDC will provide reagents for the CDC IgM Capture ELISA to qualified laboratories. CDC will also provide the protocol, primers, and probe sequences and RNA lysate for the CDC RT-PCR assay. Finally, earlier this week, CDC has distributed serology and RT-PCR proficiency panels to qualified laboratories that have requested them. It is important to consider and distinguish dengue and chikungunya virus infections. The viruses are transmitted by the same mosquitoes, the diseases have similar clinical features, and the viruses can circulate in the same areas and sometimes cause co-infections. It is important to rule out dengue, as proper clinical management can improve the outcomes for patients with dengue. This table shows the clinical features of chikungunya virus compared with dengue virus infections. The number of plus signs indicates the frequency at which symptoms were reported in studies comparing chikungunya and dengue in populations where both viruses were circulating, causing disease at the same time. In comparison to dengue, chikungunya is more likely to cause slightly higher fevers, arthralgia, and arthritis. The frequency of headache is similar, though retroorbital headaches are more classically described with dengue. Chikungunya is more likely to cause a rash, while dengue causes more myalgia and hemorrhage. Shock is generally only described with dengue virus infections. This slide is similar to the last, but shows clinical laboratory features of chikungunya compared with dengue. Lymphopenia is more commonly seen with chikungunya, while neutropenia, thrombocytopenia, and elevated hematocrit are more often seen with dengue virus infections. The differential diagnosis of chikungunya will depend on the clinical signs and symptoms, as well as where the person was likely infected. For returning travelers from the Caribbean, dengue and leptospirosis should be considered. For travelers to other areas, malaria or rickettsial infections are also in the differential. Other diagnoses to consider include parvovirus, enterovirus, group A streptococcus, rubella, measles, adenovirus, post-infectious arthritis, and rheumatologic conditions. Again, depending on their travel history, other alpha viruses to consider include Myaro-virus, which is found in South America, Ross River and Barma forest viruses found in Australia, Anyanyong virus found in East Africa, and Sinbis virus from many areas in the Eastern Hemisphere. There is no specific antiviral therapy for chikungunya virus infection. Treatment is supportive and includes rest, fluids, analgesics, and antipyretics. The patient's hydration and hemodynamic status should be assessed, and other possible serious conditions such as malaria and bacterial infections should be evaluated and treated as needed. Given the similar geography and symptoms associated with chikungunya and dengue, most patients should be evaluated for both infections. Proper clinical management of dengue reduces risk of severe disease and death, and suspected chikungunya and dengue cases should be managed as if they have dengue until that has been ruled out. Aspirin and other nonsteroidal anti-inflammatory drugs, or NSAIDs, can increase the risk of hemorrhage in patients with dengue. If dengue is in the differential diagnosis, aspirin or other NSAIDs should not be used until the patient is afebrile and has no warning signs for severe dengue. For this reason, acetaminophen is recommended for initial fever and pain control in a patient with possible dengue or chikungunya. If the acetaminophen is not adequate to control the pain, then a healthcare provider might consider the use of narcotics or NSAIDs. Persistent joint pain due to chikungunya may benefit from the use of NSAIDs, corticosteroids, or physiotherapy. However, there are no controlled trials using these medications for this indication, and it is not known if anti-inflammatory or immunosuppressive medications are safe and effective in this condition. Travelers going to areas with known ongoing virus transmission should be informed about the risk of chikungunya, ways to prevent infection, and to report to healthcare if they get sick during or following their travel. Chikungunya should be considered in patients with acute onset of fever and polyarthralgia, particularly in travelers returning from infected areas. Finally, clinicians and public health officials are encouraged to be aware of possible local transmission of the virus in areas where Aedes species mosquitoes are active. Chikungunya and dengue are now nationally notifiable conditions. Healthcare providers and reference laboratories should report laboratory-confirmed cases to state health departments. State health departments should then report laboratory-confirmed cases to CDC through ARBONET. Timely reporting of these cases will allow health departments to assess and hopefully reduce the risk of local transmission or try to mitigate further spread. There is no vaccine or medication available to prevent chikungunya virus infection or disease. The primary prevention measure is to reduce mosquito exposure. Healthcare providers should consider advising persons who are at risk for severe disease to avoid travel to areas with ongoing outbreaks. Finally, protecting infected people from further mosquito exposure during the first week of illness will prevent them from infecting new mosquitoes and contributing to the spread of the virus. The best way to prevent chikungunya virus infection is to avoid mosquito bites. When indoors, use air conditioning or have intact screens on windows and doors. When outdoors, use insect repellent and wear long sleeves and pants when possible. At a community level, mosquito habitat control and appropriate applications of larvicide and adulticide may reduce viral spread. However, experience with dengue in the Americas has taught us that substantial vector control resources would be needed to curb the current chikungunya outbreaks. The future of chikungunya virus in the Americas and the United States is unclear. The virus will continue to spread in areas with competent vectors. Local transmission was recently identified in Mexico, and healthcare providers and health departments should be vigilant for possible spread into U.S. border states. Travel-associated cases will continue to occur and to introduce virus into the United States. These imported cases will result in local transmission and likely some outbreaks. However, the use of air conditioning and other means of avoiding mosquitoes will likely mitigate the size and scope of these outbreaks in the continental United States. In addition, colder seasonal temperatures will interrupt and possibly stop further transmission. Given their similarities, dengue might provide the best predictive model for the expected course of chikungunya in the Americas and the United States. In 2013, 2.4 million cases of dengue were reported in the Americas, including 773 travel-related and 49 locally transmitted cases in the continental United States. There are many remaining questions which could impact the course of the outbreak in the Americas. It is not known what role Aedes albopictus may play in transmitting the virus in more temperate areas, or whether an enzootic cycle will be established to maintain the virus in the region. It is also unclear what the impact of chikungunya and dengue virus co-circulation will be on the epidemiology of these two diseases in the region. Finally, the overall burden of long-term morbidity is still unknown. In summary, chikungunya is an emerging virus which continues to spread in the Americas. Chikungunya virus infection should be considered in patients with acute onset of fever and polyarthralgia, especially travelers who recently returned from areas with known local virus transmission. Laboratory-confirmed cases should be reported to state health departments and CDC to help track the virus and possibly mitigate further spread. These next two slides list selected recent references with a focus on the chikungunya outbreaks in the Americas. This final slide includes additional resources for information on chikungunya, including travelers' health notices and the preparedness and response guidelines that were developed and distributed by PAHO and CDC in 2011 prior to the introduction of the virus in the Americas. Thank you, and we'd be happy to take any questions.
Thank you, and at this time, to ask an audio question, please press star 1 on your telephone keypad.
Thank you. And this is Lisa here at NACCHO. I will read the first question from the chat box for Mark. And Sam Jarvis asked, how do you distinguish from arthralgia from arthritis, lab tests or symptoms reported by PT?
So distinguishing arthralgia from arthritis is a clinical history and examination distinction. So arthralgia is the reporting of soreness or pain in joints, and arthritis would be noted by clinical evidence of inflammation in the joints, usually noted by redness and swelling or direct evidence of inflammation if the joint is tapped.
Thank you. And are there any questions on the phone line?
There are no audio questions at this time.
Okay. We have another chat box question from Neil Pascoe. What are the barriers to developing a vaccine for chikungunya and dengue?
So for chikungunya, one of the primary barriers is knowing the burden of the disease and how a vaccine would be used, because the virus causes outbreaks, and those occur periodically or sporadically, and the virus moves around. It would be difficult to know how to use the vaccine in a particular area in places that might just have periodic outbreaks or imported cases. However, despite that, there are many groups that are working on developing vaccines, and those are moving forward. A number have moved out of phase on non-human studies and are moving into phase 1 and some phase 2 clinical trials. Dengue virus has similar issues with regard to predicting where outbreaks will occur, but is a much more complicated issue because there are 4 different actual types of the virus, and that makes preventing disease much more complicated in developing vaccines.
Lynn Haramis asks, are non-human primates the only vertebrate and zoonotic reservoir animals other than humans? Any evidence for other species of vertebrates?
For the most part, certainly humans are the primary host in outbreak situations, and non-human primates are known to be zoonotic hosts in certain situations. There is evidence of other vertebrate animals being infected, but no direct evidence at this time that they play any significant role in the transmission cycle.
Are there any questions on the phone?
There are no audio questions.
Okay. Shannon Casey asks, does this specific Aedes mosquito species live in the U.S.? How is local transmission occurring?
So,
this is Roger Nashi. Mark deferred the question to me. We do have both Aedes aegypti and Aedes albopictus in the United States. Mark showed on one of his slides approximate distributions of both. Aedes albopictus is much more widely distributed in the eastern part of the United States and is spreading into other regions of the country. Aedes aegypti is primarily restricted to southern portions of the United States. The data that are available, both done in our laboratories and some published information, indicate that both are competent vectors of the strain of the virus that's circulating in the region.
Thank you. And Steve Englander asks, Does the finding of a local outbreak of the African strain of chikungunya virus in Brazil raise additional concerns for the Western Hemisphere?
So far, the reports of Brazil are just from a single or small number of cases and do not suggest any additional concern beyond the concerns already raised from the virus being introduced and spreading throughout the Americas. That will need to continue to be watched. So far, the majority of disease throughout the Americas seems to be attributed to the Asian strain, but right now there aren't really any significant differences that we would expect with regard to the further spread of the virus or disease course, regardless of which type of virus is causing disease, and we do expect that there will continue to be additional introductions of chikungunya virus from other areas of the world.
Catherine Flores asked, we had a case come through our emergency department that was suspected to be this disease. However, the physician chose not to test. The person was a recent traveler to the Caribbean. Should we be testing all suspected cases?
Yeah, I think that's a hard question to answer and is really a clinical decision. So there are reasons certainly to test. The first is to make a clinical diagnosis, and that would be to rule out other etiologies for which the patient might require other treatments. In addition, as was pointed out in the presentation, dengue and chikungunya have very similar clinical presentations, occur in similar areas, and if a patient has dengue, although there's no specific antiviral therapy, there are clinical management tools that you'd want to use to help reduce the risk of severe disease. In addition, epidemiologically, obviously it's important to know where cases are occurring, especially if there's a risk of local transmission. But we recognize that with the large number of cases occurring and returning travelers, it's not likely that every patient is going to have a diagnostic test performed, and many can be diagnosed, at least presumptively, based on their clinical symptoms and their places of exposure.
Thank you. And are there any questions on the phone line?
There are no audio questions at this time.
Daniel Nieses asked, do you anticipate additional commercial labs other than Focus Diagnostics to test for chikungunya virus this year? Will these labs be listed on the CDC's website as they roll out their tests?
So we're not aware of any other commercial labs that will begin to do testing themselves. Healthcare providers can order the test through a number of reference laboratories, and those reference laboratories will generally refer the specimens on to Focus Diagnostics for their in-house assays. However, as further work and information becomes available on the commercially available IgM kits, there may be other laboratories that take those up, or public health laboratories, especially if any of those become FDA cleared. There is an increasing amount of testing that is being done at state health departments. Prior to or at the beginning of this outbreak, there were 3 state health departments around the country that could test for chikungunya: New York, California, and Florida, as well as the CDC lab here in Fort Collins and the CDC lab in Puerto Rico. The Puerto Rico Department of Health can also do testing for chikungunya, and now an increasing number of other state public health laboratories are bringing chikungunya testing online.
Kristen Baskerville asked, does infection confer lifelong or long-term immunity?
Yes, like with most other arboviruses in general, we believe that infection with chikungunya virus incurs long-term and probably lifelong immunity.
Leah Colton asks, is there any evidence of differences in morbidity severity between the Asian and African chikungunya virus genotypes?
In general, the answer is no. Additional studies probably need to be done, especially as more of Asian genotype spreads in the United States, but so far there's not evidence of differences in morbidity or mortality between the Asian and African genotypes.
Are there any questions on the phone line?
To ask an audio question, please press star 1. And there are no audio questions.
Paul Hunter asks, should both PCR and IgM be done regardless of when the patient's symptoms started, or should the PCR be dropped after a certain number of days?
Yeah, in general, PCR should be performed for the first, we'd say, week or 8 days after clinical onset. After that time, it would be unusual to have viral RNA in the blood. IgM antibodies tend to come up about 4 to 5 days after clinical onset, so some laboratories will only test for IgM antibodies after that time. Some laboratories will test at any time due to sometimes antibodies coming up earlier or uncertainty in the clinical onset date. But in general, PCR does not need to be performed if you have confidence that the symptoms onset was more than 7 to 8 days prior to when the specimen was collected.
Lynn Haramis asks, is Aedes japonicus a potential vector of chikungunya virus? Are lab transmission studies completed on this species?
Could you repeat the question, please?
Sure. Is Aedes japonicus a potential vector of chikungunya virus? I might be pronouncing that incorrectly. Japonicus?
Yes, thank you. Aedes japonicus. I'm going to have Roger Nashi address the question.
And I consulted with Ann Powers, and we're not familiar with any laboratory evaluations of Aedes japonicus as a competent vector, and it has not been recorded as a vector in the field.
Thank you. David Gaines says, did you know that LabCorp does not consider chikungunya virus to be reportable?
I can't speak for LabCorp. It's a nationally notifiable disease starting in January of 2015, and so over time we expect that health departments and laboratories will be reporting laboratory confirmed cases.
Thank you. And are there any questions on the phone line?
There are no audio questions.
I believe we are waiting for Alina Shaw to ask a question. I can see that she is typing. Are there any other additional questions that you would like to ask our presenters today?
Please press star 1 to ask an audio question.
Lynn Haramis asks, is there any possibility that you could change the virus's name to something like nasty virus so we don't have to spell chikungunya all the time?
Sorry, that's not something we have control of.
We have an audio question from the line of Allie Swook.
Yes, I was just wondering, do we have any idea the cost of the test through Focus? I mean, not generally. I know that, providers have their own contractual pricing, but I mean, in a general amount.
I'm sorry, I do not have the cost of the tests in front of me.
Okay, thank you.
Crystal Swinger asks, how do I add a mosquito species that I find in my county to the ArboNet?
So if this is someone from a county level, they can report those data to the state health departments, and mosquito data can be reported from state health departments into ArboNet.
Andrew Hennenspet asks, on average, is chikungunya testing covered by a patient's health insurance?
I can't answer that question specifically, but as a diagnostic test, if indicated based on the clinical findings and ordered by a physician, I would assume it's covered by insurance, but I can't answer the question specifically or for all insurance carriers.
Are there any additional questions?
no audio questions.
All right, we have a question from Alina Shaw. Comment from CDC's U.S.-Mexico unit working along the border. We are wondering if it is possible for the counties in the border region to add questions about recent travel to Mexico border states or sick family members they have been in contact with. We will follow up with the states on this issue.
Great, thank you. We didn't hear a question there, but please clarify there's a question, but thank you for the comment.
No, it was just a general comment from the U.S.-Mexico unit. Joseph French asks, do you have to get a specific spray if you spray, or is it able to knock out with regular spraying?
This is Roger Nashi again, and we have a couple of people here with expertise in mosquito control. So there are two potential ways to answer this question. One is for using insect repellents, and the repellents that are recommended on CDC's webpage are pretty much uniformly effective against Aedes aegypti and Aedes albopictus. There are some variations, but the EPA registered repellents and the various formulations of those active ingredients are quite effective. If you're talking about mosquito control using insecticides, there are some insecticide resistance problems with controlling Aedes aegypti with organophosphates or synthetic pyrethroids. However, those patterns can be quite focal, quite local, and the local mosquito control programs are advised to be monitoring the insecticide resistance of their local populations in the event that they do need to do a larger intervention in the case of an outbreak.
Thank you. Are there any additional audio questions?
To ask an audio question, please press star 1.
And I believe that is all our chat box questions. And so if anyone has any additional questions for our presenters, now's the time. We'll give it maybe a minute or so, but if not, then we can probably wrap up a few minutes early.
And there are no audio questions.
Well, I think that is all of our questions for today. I don't know, Mark, if you have any last comments you would like to add before we finish the webinar?
No, I just want to thank NACCHO again and Lisa and Dave for hosting this webinar and giving us this opportunity, and we want to thank all the participants for their interest. Thank you very much.
Thank you. And if you all have any additional questions in the future, you can see the contact information up there for CDC, as well as us here at NACCHO is preparedness@naccho.org. So thank you all once again for joining this afternoon. It was a great discussion, and have a great day. Thank you.